Hey, then good morning to everybody. Welcome to new people who joined, uh, who and last time who joined. Somebody joined last time, first time. No, is not here today. It's you, yeah. You were able to still register. Were you able to register? Then I would advise you to speak. I would advise to Freya. And your name, sorry. To speak with Noam how it's if it's still possible, because Frey would also like to considering joining the course. Okay, the name of the course, especially for new people, is Pharmacology and Physiology of Neuropsychiatric Disorders, focus on monoamines. And before we go to the next class, which we already started to last time, I would like to make few announcements. I personally, on June 16, it's not day of our class, I personally will go to this event in Jerusalem at the seminar on psychedelic research and treatment. And I think it will be a pretty interesting seminar, and it's open to especially oriented for students, graduate, undergrad, graduate, and PhD students. It will be in Hadassah and Karim. I recommend you to join this event, especially I heard some of you considering to make work, the course work on psychedelics in person. It will be in person. I am not 100. Please go to the website and check. I think it will be in English, but I'm not 100% sure. Next announcement, with your permission, I am considering to change a little bit schedule of the course. We will still cover the same topics, but after I start teaching of this course and after I get some interaction with you, I think that we can make better planning for this course. Initially this is a planning as is it now. The next meeting will be an interactive visit to my laboratory, and I will be myself in Bratislava, and I will guide this interactive visit from there. So next meeting will, and from week after the week, we will come back to our in-person lectures. But we plan to cover in the next in-person language, cover histamine and adenosine, then to move to corticosteroids, opioids, growth factors, and finally to trace amines. And I was thinking there is some, it will be maybe more wise to move histamine, which is monoamine, to today's lecture, and next lecture to make about trace amines, which after all also monoamines. And after finishing with monoamines, then we will go to interaction between monoamines and other biological molecules. So it will be like this. Next meeting, interactive visit to my laboratory. Meeting after this, interaction between classical monoamines and trace amines. And then 4 last meetings we will dedicate to interactions between monoamines and non-aminergic transmitters, amino acids, adenosine or purine nucleosides, corticosteroids, and tissue growth factors. What do you think about this change of the program? Okay, very good. And then we will move to today's lecture, interaction between monoamines. Role in antidepressant and antipsychotic drug response. I will put back pointer. We already briefly started this topic our last meeting, but today I decided to start it from some, myself not clinical scientist, but we need to understand some, I would like to share with you some clinical concepts, because it will be made for us easy to understand some points, some pharmacological points which we go to discuss. How long do you think we treat patients with depression? Last class we saw that it's need at least 2 weeks to feel the first, still not full, but very initial effect of the treatment. And 6-8 weeks, we need to get a full effect. This is a treatment duration recommended by American Psychiatric Association. First episode, if just first episode of depression, it treats 6 months. Somebody they had 2 episodes, treated for years in average, and with 3 episodes go to 5 years, and somebody who has had 4 episodes of depression, 4 relapses or more, it's recommended that he will be managed with some antidepressant drugs for lifetime. But it's not all. If we have one of these complications, if somebody plans suicide, has family history of depression, if it's geriatric depression, or show treatment resistance, what at least we will see later what is treatment resistance, it lack of adequate response to the first chosen treatment, then you have 2 steps. For example, if somebody just with first episode, but with suicidal plans, you treat them like third episode. If somebody second episode and treatment resistant, then it's probably he will be like 4 episodes and he will be tried for lifetime. This is how it looks like treatment course for depression. Hysteria is like normal mood state without mood symptoms. Beginning of mood symptoms, depressive symptoms, which is still not sufficient to qualify patients for the major depression called minor depression or dysthymia. Finally, when severity of symptoms fall below this threshold, depression is diagnosed and we start the treatment. The treatment has acute states which last from 6 to 12 weeks. It has continuation till we have remission. Remission is we go back to athemia. Then we must continue. We stop to this, we will more likely to have relapse. We must continue for up to 9 months. And if it's complicated cases like we saw before, we continue even after 9 months, which is called maintenance. Unfortunately, depression can reappear in every stage. If it's reappear before remission, before full recovery, it's called recovery. Somebody consider which in remission for 6 months. If it's before recovery, it's called relapse. If it's after recovery, it's called recurrence. But it's called different name. Yes. Depression, you must have severity and symptoms, but not only. To have depression, you must have to follow exactly guidelines of DSM, Diagnostic Statistical Manual. It must be we saw it on the first lecture. It must be 2 mandatory symptoms, which is depressed mood and anhedonia, and 3 more symptoms taken from the list, like suicidal attempts, cognitive concentration, cognitive problems, appetite abnormality. We will speak about it. You should be exactly, especially if you're dealing with patients, you should be very careful to distinguish between depression, which is a diagnosis, it can be yes or no, and between severity of symptoms. Somebody can have depressive symptoms without being diagnosed with depression, for example. What do you think, how many patients you take? You have patient, you started to treat him or her with an antidepressants. How frequent, what is the chance to have remission, to reach this golden point? What do you think? Well, Alevai, we'll say. 80% is will be very likely. Unfortunately, situation which have much novel and different, but situation remains pretty similar. It's a third and third, plus minus. Full remission, it's achieved in 30 in around 30%. Another 30, one third, 30%. They show partial response. Partial response, it means some symptoms when they go down, let's say anxiety, level of anxiety goes down, but still other symptoms remain, and patients still considered to be with experiencing depression. What we do with, what psychiatrists do with, yes, please, about the, yes.
Yeah, but you say that people that from drive the one couple of partial and the one that responding on another.
It is lack of adequate response can be from different reasons. It can be from sometimes just for lack of response. This specific patient does not. Sometimes the patient feel better, drop of medication, and then they have remission. Then they have relapse. So it's good. Well, according to this, I will say it, so if you treat with one third considered to be were considered to be good responders, and these two thirds are considered to be resistant to the treatment to some degree. Yes, it can be also. It's just very general information. I don't go very deep to epidemiological aspects in this course. We need to, my idea is to understand mechanisms, and I'm not clinician myself to go very deep to this. What we deal with non-responders who does not respond, there are different strategies. Most of the psychiatrists, they change the medication. Patient comes to the, usually outpatients come to the psychiatrist clinic, to the psychiatrist prescribe SSRI. He doesn't see that the patient doesn't respond. He changed to something else. Usually, first treatment more very commonly is an SSRI, selective serotonin reuptake inhibitor like escitalopram. After SSRI, psychiatrists usually try SNRI, serotonin noradrenaline reuptake inhibitors. If it doesn't help, we go to tricyclic drugs, which are clinically they sometimes can be more efficient, but they have more side effects because we never use them as a first choice. And last sort of the MAO inhibitors, which can be sometimes pretty efficient. We will maybe in few next lectures come to an equivalence and why MAO inhibitors can be very efficient. But as we learned, and who joined us now is recommended to go to see the class as a second class. We learned that they have a lot of side effects, they're not safe. And most of psychiatrists, they change the treatment, but not always is the best option. Another option is the combination, all kind of combination. And we have three types of combination of combo treatment. First is the combination of several antidepressants. For example, if somebody treated with SSRI or SNRI, escitalopram and venlafaxine does not show good effect, you can add mirtazapine together. Mirtazapine is 5-HT3, 5-HT2A2C, and alpha-2 adrenergic blocker. Or you can add bupropion. Bupropion is very interesting drug. It was in the beginning, it was also believed to be SNRI, but now we know it's not SNRI, it's release stimulator. It's a mechanism of action a little bit similar to psychostimulants. Actually, it is to some degree psychostimulant. It stimulates increased release of dopamine and noradrenaline from nerve terminals. Also, non-antidepressants can be used as augmentation, like pindolol. We showed it last time as 5-HT1A agonist, or lithium or T3. Lithium, somebody of you reminded it last time. It was you, I think. You no? Somebody of you reminded lithium of last time. The topic which we will mostly focus today is augmentation of antidepressant by atypical antipsychotics. Atypical antipsychotics. Why? It was again psychiatrists first tried it in the clinics. It worked, and only later we started to understand why it works. We tried to understand why it works. Why psychiatrists came to this idea to use atypical antipsychotics in depression? You remember, I think it was our second meeting, we learned that schizophrenia divided to which is this disorder which usually requires antipsychotic treatment. Symptoms of schizophrenia, they are divided to positive symptoms and negative symptoms. Classical antipsychotics like haloperidol, they efficient only in positive symptoms. They don't have almost no efficiency, no effect on negative symptoms. And new generation atypical antipsychotics are efficient in both negative and positive symptoms. Both of them positive and negative does not mean that some of them good and some not good. Both of them really not good. Positive symptoms, some symptoms that patient experience during the psychotic episode, during the worsening stage. It's a hallucination, delusion, and usually psychomotor irritation. Negative symptoms they experience all the time, as they experience between the episodes, and with each episode they become more and more severe. It's a loss of interest in outside world, inability to perform basic needs, to carry about their own basic needs, such as personal hygiene. It's usually not retardation, it's vice versa. It's psychomotor retardation, cognitive decline, and very problematic social functioning. And what you see with depression, actually it's pretty similar. There are certain similarities between negative symptoms of schizophrenia and depression. In depression, we have anhedonia, which is kind of loss of interest. The depression also usually, sometimes you can see irritation in depression, but usually depression characterized by also psychomotor retardation. Severely depressed patients, they have very big problem to leave their bed. And depression as well characterized by cognitive decline and impaired social functioning. I believe it was the idea of psychiatrists which decided, well, if atypical antipsychotics, they help here, maybe there is a good chance that they can help also here. I will first introduce, before I will go now to go your results of some clinical studies with atypical psychotic antidepressant. But before going to clinical study, I will briefly introduce how we measure severity of the symptoms. We already mentioned it that with depression, without depression, can be different patients can have different severity of depressive symptoms. There are several scales. One of the scales, Hamilton depression, more common ones, the Hamilton depression scales and Montgomery-Åsberg depression rating scale, or MADRS. Usually you see it with the patients, it not necessarily can be psychologists or psychiatrists. Even somebody without medical education can be quite prepared to perform these scales. and you try to assess the severity of each symptom or symptom. So, for example, approval sadness or reported sadness. It's no sadness at 0. If it's light sadness, 1, and if it's severe sadness, all the dates hits come up to the 6. And what's very interesting is Montgomery in Mother's score. You see, you put score for how you assess the patient and how he self or she or he self assess herself or himself. You will be very surprised. When I was in my postdoctoral supervisor, who was a psychiatrist, he sometimes allowed me to participate in this in Madras follow-up of the patients. It's very interesting. So you see the patient is very different. After 2-3 weeks with antidepressant, you really see he's smiling and talking in positive way. But if you ask how sad, how anxious and sad he was, yes, I'm very sad. He will self-report can be very different with you. With your assessment, and both of them they are considered in this Madras scale. Here the study was done by Shelton. It was published pretty long ago, almost 23 years ago. He took 3 groups of patients. Some patients received fluoxetine. It was the most used antidepressant, or Prozac, most used antidepressant this time. Some patients received olanzapine, which are typical antipsychotics, and patients they get combination. And improvement, decrease in depression score in combination treatment was much better than solo treatment with one of these antidepressants, with one of these drugs, with antidepressant or atypical antipsychotic. There's another clinical study of Rappaport 20 years ago, and one of the first studies which showed evidence that atypical antipsychotics indeed work in depression. He took non-responders. He took almost 400 people who were treated for 42 days with citalopram, with a selective serotonin reuptake inhibitors, and show very little improvement. And he continued with the same patients. He added risperidone, atypical antipsychotic drug, risperidone to citalopram, and in absolute majority of these patients, 348 patients out of 386, he started to see response as early as 1 week after beginning of the combination therapy. Yes.
At what time would you testify depression?
Well, as I need to check it. Thank you for a very good question. I think it's will be something like 6-7 weeks after the first treatment. But psychiatrists now know that if after 2-3 weeks you don't see any symptoms, any slight improvement, the more likely you already need to switch or to think about it. Well, sometimes antipsychotics even can be used even as a solo treatment in mood disorders, and usually in bipolar depression, but also in unipolar depression. Because you saw in the graph that was improvement even without SSRI, with only olanzapine. What is special about, now I see you ask more questions, you ask about topics that I less know about the clinical studies. Now let's go to, finally we go to pharmacology. What's the difference from pharmacological point of view between typical and atypical antipsychotics? Antipsychotics, haloperidol, they their affinity almost exclusively limited to dopamine receptors, to D2 receptors. And it's the to 5-HT, serotonergic receptors, actually 5-HT2A receptors, adrenergic receptor, histaminergic. We will hopefully come by end of the class today, or maybe next meeting we come to histamine. Affinity of haloperidol almost absolutely neglectable. But typical antipsychotics, they are pretty different. They major affinity usually to serotonin 2 receptors. Many of them, they have pretty high affinity to alpha-2 adrenergic receptors, to histamine receptors, and they also have affinity to dopamine receptor. But some of them, this is not first affinity, they major affinity. And with the case of clozapine, and quetiapine, it's even pretty neglectable affinity. Sorry? It's it's KD. It's a KD. It's a binding affinity. It's a millimolar, micromolar, I believe. And based on the receptor binding profile of atypical antipsychotics, we can suggest there can be maybe 3 mechanisms how they work. It's noradrenergic mechanisms, dopaminergic mechanisms, and histaminergic mechanisms. And we will start with today with noradrenergic mechanisms, and probably let's see how much we able to cover today. This is one of the slides we started our course. We saw that SSRIs, when this is the effect of selective serotonin reuptake inhibitors on 5-HT serotonin neurons. When you administer SSRIs acutely or subchronically for today, paradoxically, they inhibit serotonergic neurons. And only after 14 days, adaptive changes such as outer receptor desensitization happen, and we get back to the normal firing activity of the serotonergic neurons. And we spoke about it, that these adaptive changes may be responsible for the delayed response to the antidepressant drug. But what do you think will be effect of SSRIs on noradrenergic neurons? This is my study from the postdoc. Here you see a recording from a noradrenergic neuron from control animal. If you treat animal with SSRI, with escitalopram, you start to see decrease in firing activity of noradrenergic neurons. This decrease observed after chronic, after subchronic, as well after the chronic treatment. It means, unlike with the serotonergic system, in noradrenergic system, there are no adaptive changes which bring the neuronal excitability to the basal level after prolonged treatment. We also saw that efficiency, that this decrease in serotonin, noradrenaline neuronal firing activity after selective serotonin reuptake inhibitors, it's indeed because of serotonin reuptake inhibition. Because, for example, escitalopram, which is more efficient serotonin reuptake inhibitors, was able to inhibit noradrenergic neurons after 2 days, and escitalopram, which is less efficient, no. And we co-administered escitalopram with an inhibitor of 5-HT synthesis. This we didn't see anymore this inhibitory effect. What happened if we add escitalopram together with atypical antipsychotic drug like risperidone? We see this as a control red. This is noradrenaline neuronal firing activity in escitalopram treated rats, and this is rat treated with escitalopram and risperidone together, we see not only recovery, but even increase in the pharynx activity of noradrenergic neurons. And this is another study by, yes, please. We will come to this very soon. This is another study with another SSRI and another atypical antipsychotic, done by almost in the same time when I did my study with risperidone in my postdoc. It was done by, they also found that fluoxetine, chronic fluoxetine, decrease the pharynx activity of noradrenergic neurons. And when you co-administer fluoxetine with olanzapine, it's another atypical antipsychotics, you have recovery of this inhibition disappears. And we can already suggest that maybe this is disinhibition of noradrenergic pharynx activity. Maybe this is why what responsible for this beneficial effect of combination treatment with SSRIs and atypical antipsychotics. Again, what's happening? We increase serotonin. If we increase serotonergic pharynx level of serotonin, we get less depressive thoughts. We get less patient get less obsessive about the depressive way of thinking. But from other side, increase in serotonin results in inhibition in pharynx activity of adrenergic neurons. In some patients, not all, because many patients they pretty well respond to SSRI alone, but in some patients, increasing serotonin suppress noradrenergic pharynx excitability of noradrenergic neurons. As a result, they may feel problems, for example, with concentration or with fatigue. And which receptors? How atypical antipsychotics? It was an excellent question here. Why? What is risperidone? How does it work? Risperidone is 5-HT2C, D2, 5-HT2A, and alpha-2 adrenergic antagonist. And what we try to do is called pharmacological dissection. They are not only anatomical dissections, there are also pharmacological dissections. I see a little bit more fun to do pharmacological one. And what does it mean, dissection? We saw the same result that I show you, representative neuron. Here is the overall results that citalopram with no additional treatment, citalopram with no additional treatment suppress the pharynx activity of noradrenergic neurons in something like to 25% of control from the value observed in control rats. And risperidone is not only recovered, risperidone even boosted higher to 250% of the normal activity. How we can check which receptor is involved? Let's administer to citalopram together with a selective antagonist of these receptors, and we will see what's going on. Here we co-administered citalopram together with SB24204084. It's a selective antagonist of 5-HT2C autoreceptors. There is no effect. Same inhibition like with citalopram alone. Here we added haloperidol, classical antipsychotic, which is a selective D2 receptor antagonist. No effect. When we added 5-HT2A antagonist, M100, 907, you see recovery. No, citalopram together with a 5-HT2A antagonist is no more able to inhibit noradrenergic neurons. Same with alpha-2 antagonist. When we add together alpha-2 antagonist and SSRI and citalopram, no more inhibition. And when you put risperidone, which is a combination of two of them, you have even increase. Such techniques, as I told you, is called pharmacological dissection. And what does it say? What's probably going on? This is interaction between serotonergic neurons and noradrenergic neurons work. Here we have serotonergic neuron in the raphe nucleus. It releases serotonin. Projection of axons of serotonergic neurons, they arrive to locus ceruleus, where noradrenergic neurons are located. Release of serotonin into the locus ceruleus results in activation of 5-HT2A receptors and in inhibition of noradrenaline neuronal firing activity. In addition, noradrenergic neurons, they negatively self-regulate themselves via alpha-2 autoreceptor, and alpha-2 autoreceptor, similarly to 5-HT1 autoreceptors, they can be located on the cell bodies or on the nerve terminals. It means when you add risperidone blocks inhibition here, and it blocks autoinhibition here and here. But there is something wrong about this slide. Who can tell me what is wrong here? What do you think will be a electrophysiological effect, the neurophysiological effect of 5-HT2A receptors? 5-HT2A receptors, they are GQ protein couplet. Their activation results. Yeah. Yeah. Their activation results in increase in inositol-3 phosphate, which activate IP3 receptors on endoplasmatic reticulum. It releases calcium into the cytoplasm. When what will be the neurophysiological effect of the calcium release? It will be stimulatory effect. So we are supposed to see stimulation of the firing activity after 2A activation. How we came to this, that we have decrease after the answer. So what do you think will be answer? How? Well, it might be, but in this case, answer more like obvious. That is the involvement of interneurons. The effect of 5-HT2A receptor on noradrenergic neurons is not direct effect. These noradrenergic neurons, they are not expressed on noradrenaline neurons or on noradrenaline neurons, but instead they expressed on GABA neurons. And this GABA, it's activation of 5-HT2A receptor activate GABA neuron, and GABA neurons inhibits noradrenergic neurons via GABA A receptors. Probably also GABA B involved. We will speak in one of the next classes. We will speak about GABAergic GABA serotonin interactions. We can conclude this that 5-HT neurons they inhibited after short-term escitalopram, and they reactivated after long-term escitalopram, but noradrenergic neurons, they remained inhibited after long-term treatments. It means that 5-HT2A receptors, unlike 5-HT1A and 1B receptors, they do not desensitize. Why they do not desensitize? Probably because of different signal transduction mechanism. And if in some patients, this inhibition of noradrenergic neurons might be responsible to the lack of adequate response to the treatment, and we need to add some additional drug which will solve the problem. And these drugs, they can be 5-HT2A receptor blockers, all atypical antipsychotics, they 5-HT2A receptor blockers, Mirtazapine, antidepressant drug mirtazapine is a 5-HT. Let's pause the recording. Okay, let's continue. Where is my sharing? Okay, so we talk about mirtazapine, which
Five H2 on them, but one is on them.
doesn't look like. Looks like the 5C2A, they express on GABA neurons. And GABA neurons, so mirtazapine, it's a 5-HT2A blocker and alpha-2 blocker. Now we start to understand why if somebody does not respond to SSRI, why he can feel better when you add mirtazapine together with SSRI. Another option is nifazodone. Nifazodone is also 5-HT2A blocker. It was very interesting antidepressant. I work on this antidepressants, on its mechanism of action on my PhD in Bar-Ilan University. It was believed to be fast-acting antidepressant, but unfortunately, it's almost not used anymore. I am not sure if it's still allowed to be prescribed. No, but it has have a negative effect on the liver. It's pretty hepatotoxic drug. This is the problem. Sometimes you have wonderful drug from point of view of the central nervous system effect, but brain is not living alone. We have other organs, especially liver, but you will always need to consider a liver effect of the drugs. And the nifazodone, it's also used to be as a solo treatment, as an augmentator, but it's almost not used anymore. We can use also another noradrenaline enhancer or noradrenergic system, which are not 5-HT2A or alpha-2 blockers. For example, tricyclic antidepressant drugs, some of them pretty potent noradrenaline reuptake inhibitors like dizipramine, and dizipramine also used sometimes as augmentation. Reboxetine, it's non-tricyclic, it's selective noradrenaline reuptake inhibitors, and you see like with the case with citalopram, it's also S and left and right optical isomers. And some alpha-2 blockers, which are not antidepressants and not antipsychotics, for example, like idazoxan, they also used in clinical use. Especially the idazoxan is very good anxiolytic. Some questions before we go to dopamine, some more questions about noradrenergic mechanisms.
Do they use 5-HT2A blockers together with noradrenergic enhancers?
I will say the best combinations with will be alpha-2 and blocking and 2A, 5-HT2A blockade, no, like mirtazapine or risperidone. Again, let's go to dopamine. We already briefly mentioned this last time. happens with neurons after we administer to the rat an SSRI. Same picture like with the serotonin neurons, and even more same picture like with noradrenergic neurons. After 2 days, we have inhibition after of dopamine neuronal firing activity if we treat animal with escitalopram, and again no recovery. Unlike serotonergic system and like noradrenergic system, there is no recovery of dopamine neuronal firing activity after 14 weeks. How we know that it's indeed effect of serotonergic effect on dopamine neurons? It's my good friend and colleague, Bruno Guyard, who is now a professor in Toulouse. We did this and pretty well at the same time on our postdocs. I did serotonergic, I did escitalopram treatment, and he did dorsal nucleus lesion. And if you destroy serotonergic system in the rat, its basal firing activity of dopamine neurons become much faster. If you will once work with serotonergic like models with a lesion of monoaminergic nuclei, I would recommend as a last resort to use rat lesion because the rats they become extremely aggressive. And
in matter where the are.
yes, thank you for a very good question, VTA. We are talking mostly about VTA. It was, there are two dopamine, we saw it in the previous class, there are two dopaminergic, but there are three dopaminergic nuclear areas in the brain. It's VTA, substantia nigra, and there is also dopaminergic nucleus in the hypothalamus. And usually it was believed that nigra is a motoric effect, it's a nigrostriatal pathway, and VTA it's more like smart areas, to emotions and cognition. But for example, what I learned, I am collaborating Professor Segev Barak. I don't know. Some you learn. One of we have him master student, and probably you know him. And from him, I learned new things that substance nigra is also not that much stupid and only motor. It's also involved in some interesting cognitive and emotional functions, but that's not topic right now. Before I go to the next slide, I will try to remind you again that dopamine is a monoaminergic neurons, and especially dopaminergic neurons, they have two modes of firing. They have single spike firing or tonic firing, and they have phasic firing or burst firing. Burst firing, it's a cluster of action potentials which come one after another without neuron goes full repolarization, and with a very short interspike interval. And we told this before that burst firing is more efficient in the terms of neurotransmitter release. You can see it here. You see that firing of dopamine neuron is full of this burst or clusters. And we have a characteristic in decrease of amplitude of the spike during the burst firing. And we see much less burst firing after serotonin treatment. And vice versa, after serotonergic denervation, we have more burst firing. This slide shows the effect of serotonin of escitalopram on firing rate and not burst firing. Usually we characterize burst firing of neuron by characteristics such as number, frequency of the burst, average number of spikes per burst, how many spikes in average in this burst, and proportion of spikes happen in the burst. And we see that escitalopram has inhibitory effect on all these four characteristics, on the firing rate, as well and on the three main characteristics of the burst firing. But you don't see pointer. I need to put it back. Is it back? No, it is not back. I don't know why it does not show pointer. Okay, so for this, but you can follow me without pointer. Yeah. And what's happened here? We perform again what is called pharmacological dissection. Which receptor, which serotonergic receptor is responsible on acetylcholine induced inhibition of dopamine neuronal firing activity. And this receptor is 5-HT2C receptor. In case of noradrenaline, is 5-HT2A receptor. In case with dopamine, is 5-HT2C receptor. And how we know it? We add different concentration of the selective antagonist of 5-HT2C receptors, and we see that the firing activity, firing characteristics of dopamine neurons of the ventral segmental area, they come back to the values observed in control rats. It means that, as I said, that serotonin dopamine interactions, they mediated via 5-HT2C receptors. 5-HT2C receptors, same as the 5-HT2A receptors, they are GABA, they are excitatory receptors. It means that more likely GABA interneuron are involved in the picture. This is what's happened with firing activity of, again, serotonergic neurons. They inhibited by subchronic acetylcholine, but recover after long treatment because of desensitization of 5C1A1B receptors. But same as a 5-HT2A receptor, 5-HT2C receptor do not desensitize. It's why we don't have, we don't see decrease, we don't see recovery of the firing rate of dopamine neurons. It means that we need to use some kind of receptor blockers if we want like to prevent this inhibition. What are clinically used 5-HT2C blockers? It's same mirtazapine and nefazodone. Actually, 5-HT2C and 2A receptors, they are subtypes of same type of the receptor, and many antagonists are non-specific to the efficiency, effective on both of them. And mirtazapine and nefazodone and risperidone, they are examples. This is work was done in the lab, in same laboratory when I did my postdoc, but it was done after me. We saw pharmacological dissection of the effect of risperidone together with SRI, and Chernolos and colleagues, they checked the same with dopamine neurons, but with another typical antipsychotic drug, with aripiprazole, and we see the same effect. Escitalopram inhibits dopamine neurons. It was very good. Olga Chernolos, she replicated my previous study, and she found that aripiprazole, that combination of eating of aripiprazole together with escitalopram prevents inhibition of dopamine neurons. What else we can use? Unfortunately, dopamine, there is one, we reminded one of the first lectures, one very effective dopamine reuptake inhibitor, but if you prescribe it to the patient, you can get something like 20 years in prison, so it's not very recommended. It's a legal drug, it's a cocaine, very efficient dopamine reuptake inhibitor. And you should, sorry, if you can get prison sentence up to 20 years for you. for using cocaine as a treatment. Yes, and it is efficient dopamine, and it can has a beneficial effect, but negative effect there's so much that you cannot use it. And it's not only about cocaine, because the dopamine system is so critical in addiction. You should be very careful when with all treatments when you try to target dopamine system. What can be used as a dopaminergic booster? It's bupropion. We already saw bupropion when we talk about noradrenaline. Bupropion is also dopamine. Bupropion is also dopamine releaser, but is less effective as dopamine, for example, than Ritalin, because Ritalin also can be used as a illegal recreational drug, and bupropion not. It was an attempt to create triple reuptake inhibitors, serotonin, noradrenaline, and dopamine, which will be not that much effective on dopamine reuptake side as a cocaine, and they could be used. They were developed, but unfortunately they were removed from the further development because the clinical effectiveness was not higher than selective than serotonin and noradrenaline reuptake inhibitors. It's a story. Sometimes you see very nice, from pharmacological point of view, you see very nice idea, very promising idea, but it's not developing to the clinics. No, it was not addictive, but it was not more efficient than let's say venlafaxine, and then the companies they absolutely have no reason to invest in this. If they invest in this development, and finally it will be not prescribed, not used more than previously used antidepressant, there is no economic benefit, and unfortunately it stopped many drug development. Okay, and I think we have time to start to speak about histaminergic mechanisms. We have 3 monoamines. Till now we spoke, and if you ask most of the people how many monoamine neurotransmitters they know, they will mention serotonin, noradrenaline, or norepinephrine, and dopamine. And you know, when I started to learn about monoamines, 3 monoamines, for some reason, resemble me 3 musketeers. Why? Because first of all, they are 3. Second, they co-work, very strongly co-work together, all for one and one for all. And third reason why 3 musketeers, I have this connotation between 3 musketeers and 3 monoamines, because they are actually 4 musketeers. Actually, there is a good reason why Dumas called his books 3 musketeers and not 4 musketeers, because from some reasons, 3 of them behave of musketeers in every point. Someone no, but next time when we'll have a course about literature research, we will speak about it. Now we will back to monoamines. And who is the forgotten musketeer? Usually D'Artagnan, because when book starts, he's not a royal musketeer yet. And the forgotten monoamine is histamine, and D'Artagnan becomes the main figure. Sometimes it can say histamine. Actually, maybe it's even more important monoamine neurotransmitter, but from some it was probably forgotten as a neurotransmitter because of this. Because histamine is very well known in the immune system research. For immunologists, it's one of the basic biomolecules, most fundamental biomolecules. What briefly function of histamine? Histamine is produced by mast cells, and it's when tissue damage is detected, histamine attract other cellular and molecular components of immune system, and is a conductor of is a key player in the inflammation. histamine. And actually, it's already resigned. Actually, it's believed there is one theory, what is the evolution basis of neurotransmission. It's believed the evolutionary neurotransmitters they developed from from proto-immune response in first multicellular organisms when one cell get destroyed because of the mechanical because of the aggressive mechanical or chemical agent. Then content of the cell get released and activate the protective function in nerve cells. Actually, histamine, in this sense, histamine very similar to the evolutionary, to the proto-neurotransmitters. When interest to neurotransmitters, to histamine in the brain come, I believe it's come with inflammation theory of depression. Inflammation theory of depression is one of the most fantastic, to my opinion, development in the depression research. The pioneer that founder of this, it was Brian Leonard from Ireland, which I met in several conferences. It was excellent scientist, fantastic person. And we will not cover in this course inflammatory theory of depression and the role of inflammatory cytokines, but I recommend if one of you will choose it as a topic for the work, it can be a very good idea. I can support and help with literature to find the appropriate literature. And I believe that interest to histamine in central nervous system context, I believe it's somehow connected with the interest to the inflammation and depression, which started in the 90s. And what we see that actually histamine is a classical monoaminergic neurotransmitter from all points of view. It has brain nucleus where histaminergic neurons are located, and it's called tuberomammillary nucleus of the hypothalamus. It is projected across to the distant area of the brain, very similar to serotonergic, noradrenergic, and dopaminergic neurons. It's involved in the plenty of the central nervous system functions such as condition. It has very important effect in the sleep, and awakening and awareness regulation. And it's involved in ADHD, in feeding behavior, and as well in the mood disorders. Because all other monoamines, histamine has receptors, and histaminergic receptors, they all G protein couplet receptors, exactly like all other monoaminergic receptors, with exception. Who can tell me the only exception? The only 5-HT3, the only exception. What we know about, we have excitatory histamine receptors. It's H1 AH2. H1 is G alpha Q, and H2 is GS couplet. And these receptors, you can find them in the brain and in the immune system. We have inhibitory receptors, the H3 receptors, H3 and H4, and all of them acting on alpha I protein. And H3 receptors, you can find them mostly in the brain. And in the brain, you found them mostly in the tuberomammillary nucleus, where cell bodies are located of the histamine neurons. H4 receptor, you find them mostly in the immune system.
It means that H3 mostly serves as an neurotransmitter?
Exactly. It's a hypothesis. You need still to prove it. It was our when I went to Netherlands to this company, the research company, we were working on histamine system, and exactly we wanted to check this hypothesis: is H3 receptor is an autoreceptor? How you check it? You take specific ligands. We use two ligands, pyramid and imipip. Pyramid is inverse agonist. Inverse agonist, it means very powerful antagonist. And I should make copy paste, and this is antagonist, and this is agonist. This is agonist, and this is inverse agonist. I will correct it later in the presentation. Here we check effect of H3 receptor ligands on the excitability of histaminergic neurons of the TMN. First, we injected pyramid, which is an antagonist or blocker, inverse agonist or antagonist or blocker of H3 receptors, and we saw dose-dependent increase in the pharynx activity. When you block autoreceptor, you prevent histamine from negatively autoregulate histamine-releasing neurons, and you get increase. And this increase was reversed by administration of the agonist of the receptor, which remove antagonist and activates the receptor and inhibits neurons back to the basal level. We checked it also on the level of histamine release. When you administer thiopyramid, an antagonist, you get increase in the intracellular 5-HT levels in the hypothalamus and in the prefrontal cortex. And when you administer imipip, you have or agonist and activate autoreceptors, you get decrease. Which method was used for this? Who can tell me? Exactly, yes. What is good with microdialysis? With microdialysis, you can check plenty of neuron. You can, from same dialyzer, from same fraction, you can check plenty of neurotransmitters. And when we checked levels of in prefrontal cortex, when we checked levels of histamine, we also let's check other monoamines. And we found when you inject pyramid, it increases not only histamine levels, but it also increases 5-HT, noradrenaline, and dopamine levels. It means that pyramid or 5-HT3 acting ligands, they can be they can have some antidepressant effect, or they can be enhance the effect of other antidepressant drugs. Now, a question was, does this effect on serotonin, noradrenaline, and dopamine neurons, does this effect include stimulation of corresponding neurons? And to check it, we performed electrophysiology. We made electrophysiology in the dorsal raphe nucleus, in the locus ceruleus, and in the ventral tegmental area. And we found that pyramid and imipip, they have effect only on dopamine neurons, not on serotonin neurons, not on noradrenaline neurons. It means that its effect on the dopamine system, it's a key element in interaction between histamine and other monoamines. And here I see the, I still don't know really why I don't see the pointer. I stop to see anything. You take it below mammillary nucleus, yes, you see at the bottom of the brain and very close to ventral segmental area. how you think T pyramid can increase the firing activity of the neurons in the ventral segmental area? There are two options. One option, T pyramid acts directly on the H3 receptor in the VCA, but this is unlikely because H3 receptors are inhibitory. Other possibility that histamine receptor, that H3 receptor increase extra histamine release, what we saw in previous slides, and increase histamine levels, act on dopamine neurons in the ventral segmental area. And we performed a study which showed us more likely the second option. Second option is what's happened. What you see here is very interesting. It's very interesting methods. It's called iontophoretic drug administration. You can use multi-barrel electrode which instead of one channel, it has several channels. And you can use such electrodes for the recording of neuronal firing activity and for the simultaneously local micro administration of specific drugs. You fill these barrels, these channels of the electrode with, let's say, with histamine. Histamine is positively charged because it's because of its amino group. It means if you apply positive current, picoampere current, you will get release. It will push histamine molecules out of the electrode, and that's what we checked here. We recorded it for dopamine neuron. Then we administer locally histamine, and we get increase in the firing activity of histaminergic neurons. It means that indeed probably effect of histamine is mediated by this effect of T pyramid on dopamine neurons is probably mediated by first it induced increase in serotonin in extracellular histamine, and then histamine activates VTA neurons probably via 5-HT histamine 1 receptor. And we saw that indeed atypical antipsychotics, which we saw before, many atypical antipsychotics, they also H1 receptor antagonist. Mirtazapine also acts on H1 receptor, but unfortunately it's very hard to use H1 receptor as a therapeutic targets because it will result in unwanted side effects on the immune system, such as an allergic reaction. I think on this we will finish today's lecture, and I will take your questions the remaining time. Yes, you're right. It should not. H1 antagonist may even block dopamine.
And they got drowsiness.
We will later spoke to one of the next classes about adenosine receptors. With them, both of them, we have the same problem like histamine receptors, because they are involved in many vital functions outside of the brains, and that's very maybe it will be useful when target delivery mechanism will be developed. Or right now, the only histaminergic receptor that we can target is H3 receptor because it's have very low expression in the peripheral tissues. I think you were first. Yeah.
So how you explain the microbiology results regarding noradrenaline and
Yeah, I know what you mean. Well, to be way, it does not involve firing of neurons. It can be some nerve terminal effect. It can be some effect on nerve terminals, or maybe it's a. To be honest, I don't know. I wanted to investigate it, but it was a private company, and private company decide what to do according to commercial interest. They totally lost. At one point, they totally lost further interest in histamine research, and you cannot do too much about it. Yes, please.
Can it affect like the result of long term?
It can be definitely according to mechanism that we show it can happen. If it happens or not, I don't know, and I don't know if somebody investigated it or not. You would like to take it as a work? Sleep problems is definitely because of the preplacenta histamine. Maybe you want to take it as a coursework. No more questions? Okay, I think we have only a few minutes. I don't think that we should start new topic. Let's stop here. Okay, thank you.